Good afternoon, ladies and gentlemen. I apologize for the late start of this session, but I do promise that we will finish this session on time according to the program. You wouldn't believe it, but I've actually been on a community visit this morning. I was out in the community, but I managed to get back in time to put a tie on. You know, I used to, when I used to teach medical education, I used to say that if you wanted to learn anything about medical education, then you should download 2 Hollywood movies. And those 2 Hollywood movies are Sister Act and Sister Act 2. They tell you just about everything you need to know about education. Watching Whoopi Goldberg play Sister Mary Clarence in that film is just a revelation. And there's a song in that film that goes something like, if you want to be somebody and you want to go somewhere, you better sit up and pay attention. So, ladies and gentlemen, I just need your attention just for a little while. And we're going to have a conversation here. And the conversation is going to be between myself and 4 colleagues, possibly 5. I don't know how many chairs they put out. Colleagues, and we're going to involve some of you in the audience. I've already identified some of you, so watch out. So I'm going to ask my panel members to join me on the stage. I think you know who you are. Prof. Akulu, Jackie, Kitulu, Menelas and Keshimana, Prof. Salma, Prof. Tade. Yeah. Any sitting arrangement, Prof. Where would you like to sit? Yeah, Jackie would, Salma, where would you like to sit? You want to go to the corner? Yeah. The Dean of Medicine in the corner. There you go. Yeah. And you get the other corner. Okay. Now, mercifully, ladies and gentlemen, we all know each other, those of us on the panel. And I hope you know them too. And so we're going to dispense with introductions at this stage and go straight into a conversation. And we've been given the task of talking around bridging the gap between the demand for doctors, expansion of the health workforce in Africa, the constraints of funding, and sometimes the constraints and conspiracies around regulation and accreditation. And so I have this esteemed panel, a medical school dean, somebody from the Council of Regulators. I've got that wrong, I know already. The president-elect of the World Medical Association, a sociologist from Carnegie Corporation, and the head of workforce development in the Ministry of Health here in Rwanda. So I'm going to start by asking you, Tade. Tade, this is the end of the second day, talking about all of the issues facing medical education. Salma, yeah, you know, we constantly want more doctors. It's costing us more money. We haven't got the money. We're constrained and sometimes chased around by regulators. Have we got it right to start with? Our model of higher education, the ways in which we engage. Do we need to introduce new vocabulary? Do we need to change the narrative? How do we keep the energy up as we keep doing the essential and extraordinary work that we do day by day? Tade.
Thank you, Phil. Having listened over the past 2 days, something that really struck me was that we are actually in what I'll call the times that actually demand new kind of thinking. With some of the work we're doing around the higher education ecosystem, we're talking about this is the time for what we call an epistemic rupture. A break with the way we know, a break with the way we do, and a break with the way we think about systems, about processes, in some cases about content. For instance, let's start with funding. Mobilizing and pulling resources for medical education. Perhaps the data shows that the biggest funder or subsidizer of that is the African government. Now, given the context in which we are and what we see as a breakdown on the international aid and funding structure, which to some extent also applies to philanthropies like ours, we have to start rethinking how we pay for medical education. Is there a way we can have a patient capital that actually supports medical education, supports students, subsidizes institutions? That's one. Is there a way we can actually mobilize and pull resources through a cooperative form beyond what we know? There are so many ways, there are so many untested and untried things. But the trouble is that on this continent, we have been dealing with the tested for the past 60 years. And this is since the end of political colonization. And this is the time to begin to move to things that have not been tested, to have the courage to do them. And that's what I think is basically one of the key challenges here.
Thanks, Tade. Jackie, World Medical Association, what do we need to do differently? Or in what ways should we think differently as we rise to the challenge?
So thank you for that, Phil. I'm looking at the challenges that we experience from a point of policy making, and that what the policymakers are doing and what we would like as the medical profession in terms of the spaces where we are, in terms of the absorption, sometimes seem to be at a tangent. Many times they are. And in that challenge then, how do we solve it, bearing in mind that we are sitting outside of the policy table? So my thinking is that we have to get into those spaces where the policies are made. So here, yes, we have deans of schools, we are working on what curriculum look like and everything, but there is a bigger influence above that. There's the government, there's the parliament that will make a decision on, how much funding is there for the health sector, be it for education, is it for the institutions, is it for absorption of interns, paying interns? All those decisions are made above that level. And I think we need to get into those particular spaces. And to get into those spaces, we have to be equipped as medical doctors to sit in those spaces. It is one thing to sit in a meeting of deans, and it's another to sit in a policy-making space where their conversation is on a global level, on macroeconomic level, the financial statements, and very quickly, we as the medical people tend to disconnect from that. And yet, those are the decisions that are influencing exactly how we are going to operate. In Kenya, the current parliamentary chair, the chair of the health committee, is a medical doctor. He's a very well-renowned neonatologist. But now we can have a conversation with him where he understands where that is coming from, or he can sit on that table and be part of that conversation. But to be effective in that conversation, it means we also have to tweak the kind of education we have. So beyond, and I think I had someone speak to that this morning, leadership training, in terms of us getting into management and administration and learning what that requires. We are very, very particular about how our curriculum looks in terms of training you for your postgraduate, for undergraduate, but are we equipped to sit in those spaces where policies are made? And so my thinking is that we also have to broaden what we call our medical education to get into spaces that will continue to influence what we require our medical space to look like. And even as I speak, I speak for myself. I was almost 15 years ago nominated to sit in the National Economic and Social Council of our country. And indeed, it has pillars which are economic and social, and health falls in the social pillar. Then I was young, I mean, pretty clueless on what these policy tables look like. But I was passionate about health. But my passion still was a major struggle to get the health matters onto that policy table. And that's what drove me then to go into to do an MBA in healthcare management. And after that, or now when I sit on those tables, they can't leave me behind, because I can speak to health as an economic function beyond a social function. When we speak to it as medics, we speak very social, and so they all look at us and their eyes get glazed over and they think, yeah, it's sad, and then they quickly move on to infrastructure, big things like that. And we need to, it's how we are positioning what our issues are so that we can influence. So that's some of my thinking on some of the things we need to do different.
Yeah, and I was going to come to Menelas next, Jackie, but maybe just come to Salma, Dean, State University of Zanzibar, Salma. And we've worked together before. This comment about preparing people for a world within medicine and all that involves as champions, as activists, as people who understand the geopolitical forces and the political ecosystem. Are we doing that, Salma? Are we thinking about that?
Okay, thank you very much. So let me start by giving my experience in Tanzania. In Tanzania, our situation is, we have a unique situation whereby we have a shortage of healthcare workers within the system, but not necessarily the trained medical doctors. So what I mean in that, we have a lot of pool of trained medical doctors who are unemployed. And this shows that there's a gap between what is needed from the government and what we are producing. So what we need is to align, first of all, to sit together with the policymakers, the government, to know what they need, what are the challenges, so that we can improve our curriculum. But also, another issue in Tanzania, we know Tanzania now is trying to help medical professionals. We have a student loan board who give the loan to the student university, and the priority are given to the medical schools. But the case comes to this, that when the medical student graduates and when he is employed, he needs to pay that loan. And if you see, the salary is very low. So it comes back to the pressure. The doctor will have pressure of paying the loan, pressure that the salary are low, it's not enough for maintaining his normal, activities. So I can give an example myself. I was given a loan while I was doing my undergraduate and postgraduate studies from the government, thanks God. But when I finish my undergraduate and I start working, they came and they say, okay, now we are starting, you have to repay what we have given. So it was pressure I experienced. And sometimes you see what you are left with in terms of salary is not enough So what we used to do is that we are trying to go and work in the other private health sectors. So you might find a doctor, one day he has 2 to 3 private health sector working. He will work in the public hospital in a short time, just to catch up to the other private hospital waiting, maybe the surgeries, I was doing consultations, surgery, all of that. So it was very stressful. Even the concentration work was very low. So I think what we need to do is that the government, we need to sit down and think how we can waiver or we can reduce the loan from this medical student. But also another issue is that we need to harmonize as an African, because I mentioned that there's a lot of unemployed medical students. So those students can move from one region to another, from within the continent. So we need to work together, sit as Africa, see what we can do. We align our curriculums, but it has to align with also what is needed, okay? So that our doctors can move from one place to another. I think that is it. Thank you very much.
No, thanks. And Menelas, maybe you can pick up on some of that and reflect on that in terms of mobility and alignment of curricula. And maybe you can also reflect on demoralized young people emerging from institutions. But yeah.
Thank you for this opportunity to sit with you. Let me start with a story. I was very comfortably seated at the Ministry of Health about 2 years ago, and I received very good email from the school, one of the universities in Rwanda. And it was something like, we are pleased to transmit to your good office a list of graduates that have successfully passed and they are employable. Of course, I clicked very quickly to see the names of the people and the specialty. I was surprised to find that the list was only containing 13 names. For a country of 13 million, graduating in one academic year, 13 specialist doctor to deploy. That's the moment, actually, it made sense to me that it's true. I cannot stay in my lane. Because on the other side, I had 50 director generals of hospital on the line, and everyone making a case that that doctor is mine, that surgeon is mine. Then I asked myself, why did I even wait for this email? I should have been present where the training is happening, where the licensing is happening, because after all, we are in this together. We are in this together. It doesn't have to be me teaching, you licensing or overseeing the standards of education, and you employing. We can be in the same room and make the right decision, especially that the needs, the needs are known by anyone out there. On the other hand, now coming to the candidate, we are talking about young, bright, teachable candidates who are waiting for opportunity to be accepted in programs that are not even occupied to the maximum. Some of the training program, when we just went to look into in great details, realize some of them were occupied at 20% capacity. We did not ask to go beyond the capacity. Within the capacity, how much you can do to answer the question that is given for us, or the task that is given to us. Train with quality, mind the quantity, of course, as well. License with the greatest efficiency that you can do. Be present when they're learning. Don't wait for them at the end to know that they skipped or they missed this. And on the employment side, of course, we also have a lot to do. Our role is not just to write a deployment letter, so-and-so is deployed there. We also have the fulfillment that you have to ensure is there, the career path that are there, because that's going to be answering to the satisfaction that we need to give to these trainees. Their dream is to continue all along and end up becoming a cardiothoracic surgeon and name it. So all of that constitutes the reasons that if done well, you can contain the unnecessary migration, transform the working place, put up tracks that attract them the most, like be there for them, listen and create opportunities. And as of December, we counted at the Ministry of Health that together, when we just go together, the ministries, Ministry of Health, Ministry of Education, the councils, universities, all these entities that are involved, we managed to increase our enrollment rate by 3.7 times from the historic average. That alone, it's a true testimony that it is possible if we mind the time, if we engage, we put our resources in activities or projects that will yield the highest impact. This is the direction that we should continue. And today, we can even magnify that in this consortium of 400 medical schools. That's a very big number of medical schools on this continent. I don't mind myself moving from here to Tanzania, Tanzania moving to here, because by the end of the day, this is not the 4x4 reform that we talk about. It's not a national agenda. This is a continental agenda.
No, thank you, Manlas. I mean, we have the president of the Association of Medical Councils of Africa here, Professor Joel Okulu. Sir, what are the medical councils doing in this arena?
Good afternoon, everybody. A lot has been said these last 2 days about AI. I just want to let you know that I am not AI generated. I'm real. I also like to say that if you look at your program, you'll see that the last speaker on all this program is the president of the Association of Medical Councils of Africa. That tells you where people put regulations. If you also look at the questions that have been asked, the last person to be asked is the regulator. I want you to take note of that. But I would like to say this, that I'd like to thank the organizers of this conference who have been able to bring in all of us here to come and talk about medical education. And I think I'd like to congratulate them for doing that. I see amongst us here lots of deans and service providers. But sometimes I feel that in conferences like this, we are talking to ourselves. Where are the people that we are talking to? I know some of them are here, but I would have loved to see more of them here sitting with us so that we are not talking to ourselves. Our moderator said that they are being chased around by regulators. Now he's talking about me chasing you people around. I don't regret that because it's a way of making sure that you stay on your toes. I know sometimes we are not appreciated, sometimes we are even not welcome, but that's a work that we have to do as regulators. I used to be a teacher in physiology. I'm a medical doctor, by the way, and I veered off to teach physiology. Now, those of you who know physiology, and I'm sure all of you here have gone through physiology, it's about regulations. You've got systems which have got to be regulated. If you're talking about sodium level, it has got to be regulated. If you're talking about hydrogen ions, it has got to be regulated. If you're talking about glucose level, it's got to be regulated. And that is where we as regulators come in. And when we are now talking about production of a workforce for health, it becomes very important that we as regulators come in and are consulted, and our views about what is going on is known. The association will allow me a little time to do some advertisement. Association of Medical Councils of Africa is an association that brings together all the regulators in the African region. I must say that we haven't fully got everybody on board, but the number that are there is quite encouraging, and we want to continue to attract other regulators to join, because it's a body that brings together, and we share experiences and chart the way forward in how we can regulate not only medical education, but also medical practice. All of the medical councils in Africa, they've got 4 roles. 1 is production of doctors, 2 is to license them, 3 is to monitor their performance, and 4 is to protect the society, and 5 is to advise government. Whether government listens or not, but that's one of our responsibilities. And we have tried to do just that. I just want to give you our experience, say, for example, in the East African region, that our heads of states declared that it's going to be a free movement of doctors amongst the different states in Africa, in East Africa. And to ensure that this is possible, we want to be sure that those who are going to be moved around have got certain basic minimum proficiencies, competencies, and attitudes. So what we have done in East African region is to develop what we call the core curriculum, which is used by all the medical schools that are running MBCHB programs. And this is shared, and one of the things that we have to do is to monitor whether that core curriculum is being implemented, and we check out to see what is going on in the region. And with that, we have been able to visit almost all the medical schools in the East African region, medical and dental schools. And as we do that, there are certain key findings that we have seen. Number 1 is the role of the deans. And I'm glad that you are here this evening to hear this. You've got a very big burden on your shoulders. And since you've got those big burdens, sometimes we are concerned as to how the deans are identified. You have heard from yesterday, some deans are elected, some deans are appointed, some deans come into office by what? By mistake? Now, if we are going to have people who are going to have that big responsibility, then I think we have got to see who becomes a dean. And I think I had talked yesterday about the qualities of what a dean should be as a leader, because it's important that they understand their role. And that is what we do as regulators, to see how the deans are running the medical programs. One of the things that we did realize is the deans understanding their roles, the dean having the competencies to do what they're supposed to do, the deans knowing where they sit in organization structures, their roles and responsibility, and their limits. So that's a big responsibility that we do find. And as a result of that, we do feel that there should be some minimum training of deans so that they understand how and what is expected of them and what they're supposed to do. The second thing that we did find is that governance is a big issue, how the institutions are governed. This is particularly challenging in the private sector, where we find that there's not a very clear understanding of what the governance structure should be like and their roles and responsibility. And then the third area that we found is infrastructure. Some of the medical schools lack infrastructure. Some of them have got kitchens which have been converted into departments of physiology or microbiology or something like that. And then lastly, the staffing. Many of the medical schools in the region do not have adequate staffing, especially in the basic sciences. And I think we have got to find a way of making sure that we can share the little that we have. I had somebody here talking yesterday that, can't I sit here in Kigali and teach renal physiology in some Ibadan university? I think it's possible with the new technology that we have around. Lastly, our friend here yesterday talked us through transformation. He walked around and talking about transformation. I think it is key. And where does that transformation start? It starts with us. That we have got to transform ourselves before we can transform others. I'm a Christian, and I like a passage in the Bible which is in Romans chapter 12, verse 2. If you have your Bible there, you can check out. It says, do not conform to the patterns of this world, but let your mind be transformed so that you can see and taste the good things. We have got to change our mental models if we are going to change education in this part of the world. Thank you.
Thanks, Prof. And I think the audience have just proved that we saved the best till last. Mm-hmm. Yeah?
I think so.
Thank you. Thank you. Yes. Tade, you've heard your fellow panelists. You kick-started the conversation. Any reflections so far? And I want to come to Professor Patrick Chiamanwa, who is the Vice-Chancellor of Uganda Martyrs and was the Dean of Medicine for many years with me. Patrick, you may need to put your hand up so we can get a microphone to you. You have one. Good, good. Okay. Tade.
I want to pick up from where Professor Okula ended, the theme of transformation. And I want us to think a little bit about what's within our powers and what's not within our powers. And this is why the setting up of the consortium is very timely, in the sense that we have a collective that can actually speak for us, advocate for us. Because when we think about the various qualities we need that should come out of medical education, and I really like the point from Dr. Kitulu about, being prepared, but not all of us are going to be prepared for this task. So there are certain tasks that should actually inhere in movements, in social movements. They should inhere in collective self-organizing groups. And I think the whole issue of pushing for transformation in medical education can start with different collectives, a consortium that is Pan-African and Africa-wide like this, country-based consortia or councils or groups, and that will require a couple of things. The first one is that the relationship between governments and the medical profession and medical trainers have been adversarial. Each time I see, particularly Kenyan television and Nigerian television, the doctors have dark glasses like trade unions, and they are sitting ready, trade unionists, and sitting ready to have a fight with the Minister of Labor and the Prime Minister or whoever is there. I think we need to go beyond that. We need to have a way in which, and that's where the training and the preparation for those conversations, unprecedented conversations, the kind of conversations we never really had in the clinics or in the universities. How do you speak to somebody who does not believe in what you believe in? How do you make change happen in that way? It's not all our doctors, medical doctors, that are going to be able to do that. Neither is it going to be all our deans and provosts. But there should be dedicated institutions beyond the trade union approach that actually begin to lead transformation at a much more collective level. And they're the ones who should be ready to break with the past. Because a lot of the ways in which we think about the education itself, and I will say something that came out, I was listening over the past 2 days, and I thought the very hierarchical nature, what I'll call the guild nature of the profession came out. Because the focus was on the doctors. I didn't hear enough about nurses. I didn't hear enough about other health workers that need to be brought together as a team. And yet the engagement with government, the engagement with thinking about the health sector as an economic sector. I worked in a foundation that wanted to shift the narrative from looking at the health sector as a social sector to the health sector as an economic sector. Must have a conception of changing the narrative, not just from the perspective of medical doctors, but from the perspective of every player in the health sector and the training of every player in the sense that there must be an alignment with the changing ways of the world now. And I think that's an important point on transformation. But I think we should strengthen institutions that can fight for us, that can address our needs, that can advance and champion where we want to go. And that, ties in with what the other panelists are. So who does that? It's not just one person. It's got to be institutions, and we've got to build African institutions that can do it. And we are on the pathways to that. So it's not all gloom and doom.
It's definitely not all gloom and doom. Patrick, can I bring you in at this point? And then I'm going to come back to Jackie for a comment or two.
Yes, thank you, Phil, and good evening again to you all. I'm enjoying the discussion, and it brings a lot of memories, but also insights from my previous work and now. I must say I've been fortunate to have worked in both public and private universities with medical schools. And I think there is work to do. But who has to do the work is the real question. But going back a little, I must say I've been fortunate to have worked here in Rwanda as a dean of medicine. And I say that because of what I will say later, and this is it. When you look at the life expectancy of Cuba, last year it was about 78.2.3 years. When you look at the life expectancy of the US, it's about the same, 78.3, thereabout. What does that tell you? It's not about the money. It's not about who has the resources. It's the political commitment. And when I was here, I enjoyed great success as a dean because there was political commitment. Now, how do we cultivate that? We have governments in this continent that can do whatever they please if they believe it's the cause they need to pursue. We have the military, we have the police, and that's the defense of the country. And the governments, no government will say, pay for your fees to join police. Pay your fees to join the army. No, they will train you, they will find you, they will dress you up and house you. But isn't health, isn't education critical to the survival of any population? How do we ensure that we don't leave medical training to whoever wants to do medicine, but actually make it a government agenda? And I think when Professor Okulo says the room is empty because many of the people we need to be talking to are not here, I think government is one of them, although we saw the minister opening the other day. But I think what we need is to learn as medical professionals that art of lobbying. the art of lobbying. When I was dean here, I saw the real dynamics of lobbying. It can be quite heavy. It can be demanding. But we need to learn to do it, because that's when you get the political commitment. There are loans, and we've seen the loan scheme. Actually, we copied this from the US. The US is difficult for you to have a residence without a loan. Probably by the time you leave, and our friends here could testify who are from the US training systems, you are normally in a few thousands, if not more, of dollars in debt because you've got to work. But can we afford that? And what is our employment likelihood when you finish the training? And what is the human resources for health establishment? Do we even know? I heard from my friend Menelas, Dr. Menelas, talking about this. But do we even know how many general surgeons, how many orthopedic surgeons, how many urologists we shall need, say, in Rwanda by 2030? If we don't, then it's by chance that we get an orthopedic surgeon. It's by chance that we get a urologist, because we are not working towards ensuring that the need projected for 2030 will be met. But we are hoping someone will want to do orthopedics, and so they will apply. And that's where the government and political will comes in, so that it is seen as a public good to train someone to ensure that a healthy population can be sustained so that there can be productivity. So the funding cycles, therefore, have to be rethought, and this is where the transformation comes in, because we are all referring to how we've funded them before, but I don't think it's going to work going forward, because times are changing, and these days, medicine is not a very fancy profession that young people are running to. People want quality of life. No one wants to be on call for the weekend. No one wants to be called away from their child's birthday party to go and attend to a burst abdomen or a ruptured spleen or something. So it's becoming less attractive. And therefore, we need now to see a different approach so that people can come in, we give them the support that they need, but we need to come together as health professionals, as medical councils, to make that case in parliaments, at the ESC, at the AU, in our own countries, so that the governments can see this as a public good. And once again, I congratulate Rwanda for making this a public good, because they see health as a public good, and I think they are doing very well. I was happy when we were able to get the Human Resources for Health program here in Rwanda to run for almost 10 years, and that was because of government support. I didn't get that as a dean, nor did Phil get it as my vice chancellor at the time, and our principal and later vice chancellor. But we saw the public good intention of government to see that the health sector is improved. And when you look at Cuba, which I started with, it has a very high life expectancy. But Cuba's greatest export is medical professionals. Everyone in Cuba is assured of some basic health care. But it's not a very wealthy nation. So, as I conclude, it's about the will of government to see this as a public good. Thank you very much.
Thanks, Patrick, and it's wonderful to be reconnected as always. I'm going to come to Jackie. I mean, we are in this together, Jackie, and there is a bright future. I'm going to come to you, Jackie, and then I'm going to come to you, Selma. Yeah?
So thank you, and thank you, Prof. Even as I was listening to what you are talking about and seeing the power of collaboration even in this new direction. And the consortium that has been formed here today is one of those powerful tools of making a difference, because then when you speak as a voice, a continental voice, and you're speaking to each other, it begins to shift the way, the perceptions, and to listen to you in a different way. It's the same thing in the medical associations. We are talking about a coalition of African national medical associations that they can, we are loosely formed, we are there, but again, if all these bodies are speaking to the same issues and can get out into that lobbying, then I think we'll move a lot further. But back to where I wanted to go to. I know Professor Kulo said, is the last one to be to speak. But there's also a missing element in this panel here, the young doctors. Because we really have to quickly rethink, where are we going? We are churning out medical students. The private sector has a limit of how many they can take. Governments have their restrictions. I'm sure Menelas will tell us more about that in terms of how much they can absorb. But then if they are going to invest, and very heavy investment in training those doctors, then there must be a place for them to go. And that is the quick discussion and the quick thinking that we have to think, where are they going? Because we have very many frustrated young doctors now. And in Kenya, we've seen a very scary trend of young doctors dying by suicide because frustrated. I have done this, I have studied, it was difficult, and then I have nowhere. So we have to start thinking of where else will they go. We do appreciate that there is a major challenge. We do not have enough of them in the spaces they need to be. And that's the lobbying part that we are working on getting that. But also, where else can we have them gainfully employ their skills? And some of the young doctors have actually gone on a very innovative approach. We've been talking about AI. They are literally in the space where they are developing applications. So we're talking about many of these applications, and there's one of the sessions that I moderated on yesterday. And it is the young doctors who are getting into those spaces to develop those models of AI that will transform how we practice medicine, how we engage in medicine. So we need to, those are some of the areas we also need to plunge into and involve the younger doctors. How do we change this space? And we cannot be the ones dictating it. We need to draw them into these policy tables and these higher level discussion areas so that we can come up with a direction that embraces all, but also provides opportunities. Indeed, as we are all, I don't think there's anyone here who disagrees with the need to embrace AI, but then if we're embracing it and all its challenges, let's draw in those who are engaging more with it on a day-to-day basis. So, and that's the group that I feel we have not directly involved in this conversation, and yet we are saying there's a challenge, we are training, they're going nowhere, but then can we also involve them in this discussion? And some have actually gone on a full-on tangent. When the flight I came in on Sunday was flown by a doctor pilot. So the doctor has left medicine, he's a pilot, and he's the one who flew me in. So, but do we want to train the doctors then to go and be pilots? I mean, we need them to also be in the spaces where they're delivering on that profession. So we need some really quick thinking around all these various different opportunities that we can engage in for the profession. Yes.
Salma, keeping young people engaged, young professionals.
Thank you very much. I will come back to what I've said. We need to have one African approach. That means we need to sit together, harmonize our curriculum, plan our strategies, which goes along with what the continent needs, so that we can absorb those healthcare workers who are not unemployed. But also I was thinking, we as Africa, why can't we learn from what Europeans are doing? Because I will give an example. I've been getting a lot of Erasmus program, whereby I will move from my country to Europe to teach for 2 weeks, and they will bring their lecturers to our country to teach. So why don't we as Africa sit down? And I want to propose this to our newly elected president of the consortium. We need to sit down and think how we can start this mobility program between lecturers, students, our medical students, so that we can learn each other and build a beautiful thing. Thank you.
Thank you. That's the first challenge you're throwing to the newly elected
Yes.
president. Okay, don't know if they're in the room. Menelas.
Yes, I think we hear a lot, especially with the regulatory colleagues, that you have to harmonize things and have things done in a way that is perfect. But I can tell you, it's already too perfect. But we fail to organize that. Because if someone can take a plane from 1,000 miles and take your nurse from Tanzania or your dentist from Ghana, it's not because they have deficits. What's missing, maybe that's where Professor Jamal wants to allude to, it's to make sure that we have all these synergies in places. We are able to showcase what we are doing. We are able to communicate efficiently. We are able to reach out to these other entities that we often, I agree, that we often reach out to, like the Ministry of Public Employment, or Ministry of Finance, to make sure that we have our numbers right in the right place. You can forecast who you need and when. We have these documents here. We know how many dentists we should employ by 2028 or by 2030. But I can tell you they are nowhere to find. It's very rare to find a midwife. It's very rare to find an anesthesia provider. It's not because, and it's not always because we don't have teachable, young, and bright people. In our medical school, we are only able to absorb 10% of the total eligible, bright, young people who are actually in the right position to do the digitization, all these fancy advanced things that ourselves we are no longer able to do. So we just have to realize how much we are sitting on gold. We have to realize that, communicate efficiently, invest in the right direction, and put aside other things that might be. And also the documents. I was going to miss that. Maybe Minister Saben would have said it. These strategic plans, roadmap, visions that we often package in 300 pages that no one will read, as if there's a secret that you want to hide there. We should be able to simplify it. What actually do we know what we want to do, and we are able to communicate that in the simplest way, in the way that is readily implementable. You don't have to flip in those pages. That's why in the end, everyone gets back in their corners, because the communication at the start is not always easy to navigate.
Yeah, it seems that we're very good at strategy and strategy documents, but when it comes to implementation, things begin to go a little bit differently. Prof. Okulu, any closing comments from yourself, sir, on what you've heard?
Thank you. I think one of the things that have been said about movements of doctors between the various states in Africa is the issue of who are these who are moving across. In other words, there is some kind of barrier in the movement of doctors from one country to another. I know the problem that we are having in the political field is that many of us still have got to look for visas to come to Rwanda, visas to go to Uganda, visa to go to Nigeria. By the way, tomorrow I'm going to attend an interview to get a visa to go to Nigeria. And we want to see in the medical field that those barriers are removed. And my vision is that in the not too distant future, as president of the Association of Medical Councils of Africa, is that there should be no barrier in movement of doctors from one country to another. There should be reciprocal recognition, there should be reciprocal recognition of their qualifications, and therefore they are employable in any part of Africa for a start. About the world, that could be a different cup of tea, but for a start, we would like to see that there is that free movement of doctors from one place to another in the African continent. And I think that is possible.
Thank you very much. Anybody in the audience with a microphone? Yes. You don't have one at the moment, no, right. Can we get a microphone to this gentleman for comments? Yep, microphone's coming. If you stand up, then we'll be able to identify you. There you go, thank you.
Yeah, thank you very much, and I think this is a very important session. The politics and the policies, particularly with respect to the medical curricula, is what I want to highlight here, especially in the context of our professional identity. Of recent, we've seen a lot of changes in especially the curricula of the allied health sciences, some of them taking some aspects of the medical curricula and expanding or extending their duration of training, the issue of task shifting, task sharing. To what extent do we really maintain our professional identity, and particularly also in the context of the postgraduate training? You know, in Nigeria at a point there was this argument that you need a PhD to rise to become a professor. If you have the postgraduate fellowship, you cannot progress. I think these are very important issues that need some common and concerted approach to address them. Thank you very much.
No, thank you. Any other comments? We've got about 12 minutes left. Prof. Lukoy, I think, from Aga Khan.
Thank you. Thank you very much. And thank you, panelists, for a very enlightening conversation. I just have an observation and perhaps a question that historically we've been measuring, and I think, Phil, you started by saying something around a shortage of doctors or inadequacy of doctors. And I think historically we've been being told that the measure for adequacy is a certain ratio between the doctor and the population. Do you think this is a good metric? Might it be better to measure the proportion of people who need a particular service who actually get access to it as the metric, rather than saying if you have one doctor to 10,000 people in the population, then you're somewhere? I think that's my concern. Thanks.
No, thank you very much. Other contributions? Sorry? Yes, thank you. Anybody over this side? We've got about 10 minutes left.
All right, thank you.
Peter Angood on the front here. Anybody else?
Right, thank you.
Thank you.
My name is Professor Sebastian Eliasson from University of Cape Coast, Ghana. So I'm just thinking, as doctors, have we been able to determine how much it will cost a country if there were no doctors? And let me give COVID as an example, the period COVID. Were we able to determine the cost to a country if there were no doctors at the forefront fighting COVID-19? So these are things as doctors we need to be economical in our thinking, to cost how much we are worth, so that if we engage governments, they can prioritize, the engagement of doctors. Because I can see many doctors have graduated and are not employed. It's not that the country does not need them, it's about priorities, prioritizing. Where do we put our money? So I think that we need to rethink as doctors to be economical in our thinking and to cost how much we are worth, so that we can engage governments, strongly at the table. Because many a time we are busy working in the OPDs, in the theaters, and we are not at the policy table because we don't have what it takes to engage policymakers and governments. So this is my take. Thank you.
Thank you very much. Let's go to Peter Angood here. I've got two hands here. I've got one hand up there. If the people with the microphones can identify the three hands that I've just identified, that would be fantastic. So we've got 9 minutes left. Peter.
Well, I have to stay under 9 minutes then, for sure, right? Peter Angood, President and CEO for the American Association for Physician Leadership. And I have been totally impressed with the language over the last couple of days. And what's impressed me is the opportunity that this continent has to do what you're talking about so much better than some of the other developed countries. It's a unique opportunity. In the United States, we have about a $5 trillion per year expense in healthcare. It's almost 20% of the gross domestic product. And yet our rankings in the OECD healthcare outcomes continue to deteriorate. Our errors in diagnosis and our errors in care continue to be in and around 10 to 15%. 27% of our physician workforce is from the international medical community. And we have a distribution problem across the country as well. And when we look at clinical job types in the United States, I counted it up, there's almost 75 different clinical job types. And yes, that patient-physician relationship is still the dominant one. The physicians are still the dominant ones. But yes, as a point was made a moment ago, there is encroachment in the other professions, the other clinicians. And should we oppose that? No, we should learn how to work together in a more interprofessional way. And so, yes, we need to continue with the importance of physicians in our training, but we need to shift. And as we think about that shift, we may have to redefine what actually the role of physicians are in the workforce. And if we're going to do that, we need to just have the support of the other clinical disciplines, but we also need those higher levels of policymakers. They need to understand what's going on in healthcare. So thank you so much. Wonderful panel.
Thanks, Peter. Let's go to gentleman here, and then we've got somebody here, and then there was a third hand at the back. So, yeah. Yes, it was the gentleman in there. Right. I think the mic just warms up a little bit, maybe.
Thank you, Mr. Speaker. I'm Samir Shaheen. My name is Professor Samir Shaheen. I'm a professor of pediatric orthopedics, and currently I'm Vice Chancellor of the University of Medical Science and Technology, Kigali campus here. Actually, I would suggest that we have to empower the medical councils in order to accomplish all what we have said today. Because if we empower that medical council association, it will dictate the accreditation of all these colleges, and it will come with a consensus of what competencies we need from a graduate, so that this will unify the standard, and it will make easy that doctors or medical students will go from a country to another without boundaries, because there is 1 yardstick for all those. Thank you very much.
I'm sorry, my brother. I couldn't see you. I'm sorry, I didn't recognize you. There you go. Thank you.
Reginald Machaba Hove from Zimbabwe. I think one of the big challenges which was mentioned yesterday in the opening ceremony by the Honorable Minister was the dichotomy between Ministry of Higher Education, where medical schools usually fall under in the state setup, and the Ministry of Health. And I think that's something which is a challenge which needs to be resolved. He offered some early discussion on that, but I don't think we've had ample time to discuss that. I just want to say in Zimbabwe, some years ago in the 90s, when I was Deputy Dean of the University of Zimbabwe, there was a platform that was established which was called the Joint Health Commission, or Joint Health Planning Commission, which was chaired by the Dean of one of the medical schools, then only the University of Zimbabwe, and consisted of the permanent secretary in the Ministry of Health and other training institutions. And then it fell away. So you have the Ministry of Health saying train 100 doctors when perhaps our capacity to train is only 30. But I'm glad to say that on the 10th of April, they've rejuvenated that system. And I thought that's something maybe we need to look into. When it comes to training of nurses and so forth, that's done by environmental health officers, that's done by the Ministry of Health. But for doctors, it's Ministry of Higher Education. I thought we should just bring that to the table.
Thank you. And our third colleague, thank you.
Thank you very much. Professor Richard Idro, Deputy Principal, Makerere University College of Health Sciences. We have had a delightful 2 days and with lots of discussions. And as we come to the end of this particular session, I'd wanted to put to the panel, as we wait for the coming year to meet again, or 2 years to meet again, what 3 things, or 2-3 things will we all go with that we focus on during the course of this coming year, of the many things which we have discussed, something to go with and work on as we look forward to improving the medical training in our institutions. Thank you very much.
No, thank you. I'm so grateful to you because you've just given us a great way to close the panel. So I'm going to ask each of the panelists. I'm going to say, what are the 1, 2, or 3 things that are on your mind that you might take away from the last 2 days and put into your own version of transformation over the next year? And let's not leave it 2 years until we meet. Let's try for a year. So who am I going to go for first? Jackie. Well, something, 1, 2, or 3 things. Then I'll come to Prof. Okulu, and then I'll come to Salma, and then I'll come to Tade, and then I'll come to Menelas.
All right. I think number 1 goes back to where I started, that we have to be on the policy tables where the policies that are made to influence how our environment operates is. And indeed, I find it very impressive that in Rwanda, the minister is a medical doctor. You have Menelas here, is a medical doctor. He can actually be someone who can actually lobby for the right things to be done from a point of being in the shoes of the medical doctor. So, and to be in those spaces, I'm saying again that even in medical education, we need to expand our medical education to ensure that, yes, that the doctors also have the ability to engage at policy-making level and that they are trained to do so. I think sometimes we shy away because I know when I did study, we had negative marking system, and if you got it wrong, you got a minus. So it actually stops you from engaging because you say, I'm not sure, so I won't engage. So if you came from that level of training, then let's get you trained to be a lobbyist. And as someone spoke there, we must lobby. And the second bit is in terms of the power of our medical councils. And someone did ask that question around it. Our medical councils, indeed, we need to ensure that they are powerful medical councils. They are the regulator, so that even when we have that disparity between what government wants and what is good for the profession and for the quality of service to the patient, the medical council should be able to stand firm and say that, okay, fine, you'll want to have 500 or 600 students per year in this university that doesn't have the capacity. And one of the things that councils do is say, okay, we'll have an exam at the end of it. You shall graduate, but you'll have to pass an exam that shows you are competent to do that. You see, that forces a rethink of how, you know, the numbers and even the way that then the systems are put in place. I know within the East Africa Joint Inspection Team, when we have had a joint inspection going out and we're going to various countries, it is the most beautiful things. Governments jump in to ensure that their medical schools are on point. They ensure that they have the right quarters of staff, that they have the right infrastructure. So there is a lot of collaboration that has to go on, and the minister is looking at me, but but yes, it is one of the things that happens, that it makes good things happen. So thank you.
Jackie, thank you. We're officially over time, ladies and gentlemen, which means that I'm going to go to Prof. Okulu and ask for 1 minute on the one thing you're going to take away that's going to transform your year.
Yeah, before I say that, I just want to thank the Minister of Health for a very informative speech that he had yesterday. I think they displayed a man who understands what the health needs of this country is and what is required of him and what he's doing about it. I was really moved by his speech. Now, having said that, I would like to thank Jackie for saying what I wanted to say. I think she has done it very well. But the takeaway point is there, we need transformation. And the question is, if not now, then when? And if it's not by us, then by who? Thank you.
Thank you. Salma.
Thank you very much. They have already mentioned some,
right.
But I will say one thing, that communication is the key. We need to communicate the university, regulatory bodies, even the government, so that we can all have one common understanding to go further. Thank you.
Thank you. Tade.
For me, I think there's been a lot of positive energy around here. I'll take away the need to support and strengthen a platform for collective voice and action, like the Consortium, so that actually builds the momentum and harnesses the energy of, you know, what we have been doing over the past 2 days and the various aspirations that we have. So support for and strengthening of the platform for the voice and action of this group.
Thank you, and I know you mean that, Tade. So thank you very much indeed. Menelas.
Thank you. I think I will maybe highlight the togetherness. Let's come together, the councils, the schools, the ministries, Ministry of Health, Ministry of Education, and we synergize efforts. We remove the duplicates. We teach from Accra, teaching a class in Rwanda, as it was mentioned by Professor. And also we take advantage from the strong political will, political support that we have. There is an African Union Health Workforce Charter. I think there was a meeting in Gaborone. The next, I think it's in mid-April in Addis, which had to be cancelled, by the way, because of the representativity. I think some of the councils and the countries did not confirm on time. But there are many opportunities that show that we have a strong support, and let's just do it. Thank you.
Let's just do it, because we're together in this. Ladies and gentlemen, please help me thank Salma, Joel, Jackie, Tade, and Menelas. People are taking photos, so we'll just stand here in that area. I didn't see it. There's a friend there. Oh, look, we have some official photographers, ladies and gentlemen. And Professor Sanayas is helping out here. Thank you very much.
Thank you. Thank you, Professor Cotton and the panelists. I kindly request that we settle down so that we start the closing ceremony. Ladies and gentlemen, please help me in welcoming Dr. Eva Butera, Minister of State, Ministry of Health for the Republic of Rwanda, and Professor Senait, the Vice President of the Global Program at the Susan Thompson Buffett Foundation. Good afternoon, everyone. Good afternoon. We had the same energy in the morning. Can we keep the same energy this afternoon? How is everyone doing? Nice. Ladies and gentlemen, we are going to start the closing ceremony. Yeah, I like now the attention that I'm getting. For this closing ceremony, please put your hands together to welcome the President-elect for the Consortium of Medical Education in Africa, Professor Lionel.
Good afternoon, everybody. I spoke in the Assembly of Deans earlier and spoke about Jomo Kenyatta saying that we're the architects of our own future. Because I think this is the place that the Consortium of Medical Schools in Africa occupies now. We plan, as we consider ourselves, to launch a consortium here in this outstanding gathering of Africans and partners. But we also launched this consortium at a moment of commitment to gathering Africans in pursuit of African solutions. The consortium sees itself as a dynamic interaction, essentially, of people, policy, and the promises we make. When we think about the people, I think it is various sectors gathered as we are here: students, deans, professionals, and professionals across many different sectors. But also this idea of policy and the conversation around curricula are beginning to surface again about whether we can do the same things for the same reasons. But perhaps we gather especially to make a promise that because we were here, the outcomes for our people will be different in another generation, or perhaps immediately. But also because we want to be sure that we can change the health outcomes of people as an essential thing. What we've done is quite remarkable. I think in a process that we began to be true only about 5 or 6 months ago, in a conversation that started with 13 deans and grew to 34 deans in the next meeting, and then 68 deans in the third meeting. I think what we've done is quite remarkable, because what it's allowed to happen even in the rooms in our meetings over the last 2 days is to create and sustain this incredibly generative spirit. this constant questioning, this constant engaging with the realities of what we are planning as a consortium. This afternoon, I was elected as the president of the organization, and so I want to invite the rest of the EXCO to come up and join me on the stage here. Yvonne Akotoa De Adomako is the vice president and chair of the Audit and Compliance Committee. Abebe Bekele is the Secretary General and Chair of the Advocacy and Partnerships Committee. And I want to say, and we are grateful that the UGHE has also agreed to be the domicile for the organization, at least in this first term, as we find our feet in the world. Salma Abdi Mahmoud, the Deputy Secretary General. Angela Frank Briggs, the Treasurer and Chair of the Finances Committee. Lukoye Atoli, the Chair of the Leadership and Professional Development Committee. Titus Sibekwe, the Chair of the Research and Innovations Committee. And Chokum Simon Pierre, Education and Curricular Committee Chair. And so, colleagues, what we've thought to do in this next few minutes as we gather as this EXCO, one of the things that we committed to is to make sure that there's regional representation. And really, without any engineering of that process, the colleagues here come from the 4 regions of the World Bank that cover Africa. And so we are deeply mindful of this sense of inclusivity, both across demographic ideas, but also across language, and ensuring that all languages are represented in this EXCO. So in a way, I'm going to ask the EXCO now to sign with me a page in this constitution. So I have to say, in a remarkable feat of engineering, after the conversation of the Constitution was had yesterday, this document has been created overnight. And it contains all of the changes to the executive committee structure that we agreed yesterday. So I really want to congratulate those who have assisted us in getting to this point. And so, colleagues, we will each take a turn to sign this page as the elected executive committee. All of the deans who have committed themselves to the consortium have, just after the elections, signed this document already. And so it remains just for the 8 of us to attach our signatures to the document. And so I want to just acknowledge that this talented, gifted group of Africans was elected from an equally gifted group of people nominated for the various posts. And so in a very collegial election, which was led by Jackie Kituli, Ricardo Borges, and Champion Nyoni, ensuring the independence of the process, this is what has emerged. What we have committed to, though, is co-opting those who have already indicated their willingness to serve into various structures, the 4 committees as we've decided on them. But let me just conclude in this moment of excitement for me, really, because in the last panel, just before we started this one, somebody said, if not now, then when? I want to add, if not us, then who will do the work? And I want to answer on behalf of the consortium, here we are, ready to do the work. Thank you for the confidence in us.
Congratulations to the Executive Committee, and congratulations to the Dean for this remarkable or significant step. Another round of applause. Next, we are moving to the special awards to recognize oral and poster presentations. Please allow me to welcome Professor Roy on stage. To give out the awards, please allow me to welcome Professor Bebe Bekele and Dr. Joseph Rattigan.
Thank you, Mimi. It's been an academic feast for the last 2 days. We had over 200 abstract submissions. Of that, we've managed to select 30 oral and 60 poster presentations. I'm sure you all had time to see all the posters. And there are 2 categories. One is of the students and one other faculty and non-student category. So it's my pleasure to announce first the poster presentation and the best student presentation for navigating consent, understanding knowledge, attitudes, and perception of sexual consent among university students in Malawi goes to Rudo Masandeke. The best non-student presentation was Open Textbooks as Digital Public Health Goods for Transforming Health Education. And it's the University of Cape Town, Glenda Cox. Anybody else from UCT who can collect it on her behalf? In the category of Best Oral Presentation, student category, exploring the emigration intentions of Nigerian medical and nursing students, destinations, driving factors and implications, University of Ibadan, Abigail Olawumi Oyedukun. The best oral presentation in the non-student category was in a session we've recently finished in 4B, which is Somalia's medical education and regulation, a review of the health regulatory landscape. Mohammad Mustaf Ahmed from Simad University, Mogadishu. So can I call all the winners on stage for a group photograph and with their deans, if they're willing to accompany them, for a group photograph, please, quickly. Huh? Professor Phil Cotton, please. So besides the certificates, there's going to be a cash award of $500 to all the winners. So this is representative of that. Thank you, everyone.
Congratulations to all that have been awarded. Next, we'll have a vote of thanks from Dr. Joseph Rethinking, to be followed by Professor Abebe. Thank you.
Thank you, everyone. I'm Dr. Joseph Rattigan. I have the great privilege and honor to serve as the chair of the Board of Directors of the University of Global Health Equity. And on behalf of the Chancellor, the Board of Directors, the Vice Chancellor, and all of the faculty and staff of the University of Global Health Equity, I would like to thank you for joining us at this conference. Murakoze Cheyenne. It has been our honor and our privilege to host you today for the past 2 days. Although we are a young university at UGHE, compared to many of the schools represented here, we are so grateful for your participating and sharing your wisdom and experiences with us. I would like to also thank all of the organizations who have helped sponsor this conference, especially the government of Rwanda and the Gates Foundation. This conference would not have been possible without the hard work of the UGHE staff, and I'd like to recognize them right now. Can you folks stand up and raise your hands? Thank you so much for all you do behind the scenes. And I would particularly like to thank 3 individuals. Ms. Claudine Mimi Segura, our MC who worked tirelessly and long hours to bring us all here together. Dr. Phil Cotton, the Vice Chancellor of UGHE. For sharing his wisdom, his warmth, and for welcoming us all here over the past 2 days. And I would especially like to thank Dr. Dean Abebe Bekele for his tireless work and effort in launching UGHE's medical school and fostering its growth, and for his visionary leadership in bringing us all together today. Thank you, Dean Abebe. With your permission, I will offer a few remarks about what we've talked about over the past 2 days. And although we have talked about healthcare professions, as Professor Tade has urged us to in the last talk, I unfortunately will focus my comments on the profession of medicine, which I know best. All of the health professions are being transformed, both by social forces and technological advances. We've heard here today and yesterday that we must learn to embrace these technologies, and especially the ones that promise to improve the health of our patients. This will not make our jobs obsolete, we've heard, but it will make us more effective and transform how we deliver care. They will also transform how we educate our learners and students. Since the earliest days of our profession as physicians, thousands of years ago, our profession has relied on the willingness of practitioners to train the next generation of physicians. For most of those several thousand years, our profession had little to offer patients that would meaningfully change the course of their illness. What we could offer them was our compassion, our caring, and our bearing witness to their suffering, the grounding that V.C. Cotton spoke about in his remarks. We were the ones who attended the sick and the dying and reminded them that although their disease had robbed them of many things, it had not robbed them of their humanity. These are the lessons that the machines will never teach us or teach our students. Yet these are the lessons that each of you practice every day, and each of you teach your students every day, just like generations of physicians have done in the past. Thank you.
Thank you very much, Dr. Rattigan, Board Chair of UGHE. I'd also like to share stage with the Board Chair in giving some vote of thanks to almost all of you who made this thing a reality. I guess this is where I take credit for all your work. First of all, through the Board Chair, we'd like to express our gratitude to the Board of UGHE that gave us the permission to host this gathering. The Paul Farmer Collaborative, that is a partnership between UGHE and Harvard Medical School for the guidance and the financial support. And the funders you see here. Without their support, this wouldn't have been possible. Please join me in giving them one round of applause. The second is to two groups. Our International Steering Committee that met every 2 weeks for 6 months, then every week for the last 3 months, to give structure to what we just did and make it presentable. I guess it was presentable. So thank you so much. And the group of deans. As the incoming president mentioned, it was just 16 of us a few months ago. The last meeting we had was 96. And today, 137 deans, in person and virtually, got together to create the very first consortium of medical schools in Africa. We are now joining ranks with other consortia like CONSAMS, like the Nurses Association, the Anesthetists Association, and we probably reach a stage where we can contribute significantly to the continent, just like what the AAMC did in the US, established 150 years ago, just like what AMI did 50 years ago. So deans, thank you very much for bearing with us. Thank you for sharing the vision. And I just can't seem to understand how not even one dean opposed this idea. I'm so grateful, I'm so thankful for all your support. The third is for this beautiful human being, Phil. Your partnership, your friendship, your guidance to the setting up of this consortium, attended all the meetings, guided all the discussions, for being there. Truly appreciate it. And most importantly, my colleagues at UGHE. Again, I take credit for everything they do. May I kindly insist, everybody at UGHE, please stand up and get recognized. Please stand up. Thank you so much. Thank you so much for everything you did to make this event successful and beautiful. This team was led by, I need to mention 3 individuals. Mimi. I'm sure all of you have received 100 emails from her, probably at 3 a.m. in the morning. I don't know what time that lady sleeps. Mimi, where are you? Dr. Victor. Dr. Olu and Rosaline. Rosaline is the big engine behind. Very quiet, somewhere hidden, somewhere. So these are the individuals and the institution that actually made this thing happen. On the behalf of all of you, please allow me to thank all of them. And we're very, very grateful to host all of you here. The highest honor in the thank you goes to the Minister of Health, the Ministry of Health, that shared the idea, shared the vision, supported us all the way. Conference opened by one minister, closed by one minister. This speaks volumes to their level of commitment. Thank you very much. Now, please allow me to invite our closing remark, keynote speaker. I texted her a few minutes, about an hour ago, and I said, how can I introduce you to this meeting? She said, as you wish. What she didn't know was I also emailed her office. And they sent me a 7-page citation. And all of it is true. So I will not do justice if I scramble and say sentences about, just suffices to say, a very good friend, lady who has fallen in love with Africa, with Rwanda, and who's been the pillar to growth in education and healthcare in Africa, and a true supporter of all of us here. Please join me in welcoming Professor Senait to be our keynote speaker.
Muraho. What an incredible honor to be here. Distinguished deans, all 137 of you from 30 countries, physically here in the room and virtually present, esteemed colleagues, ministers, professionals, partners, policymakers, researchers, scientists, but most importantly, healthcare professionals, students, really the future of our continent. It's an incredible honor to stand in front of you today as we close this important gathering, one that has brought together brilliant minds across from Africa to rethink and reimagine medical education. Our continent faces immense health challenges, from high maternal mortality and infectious diseases to the growing burden of non-communicable diseases. At the same time, our countries are navigating a rapidly changing financial landscape with declining international support and increasing domestic pressure. Yet, I stand before you very, very hopeful, because despite these challenges, we have a choice: either to let those obstacles paralyze us, or to use them as a catalyst for transformation. We have the talent, the institutions, and the willpower to drive change from within, and that's what we witnessed with the launch of this consortium today. And at the heart of this change is how we educate and train our healthcare workforce. So absolutely, this is the time to reimagine medical education in Africa and for Africa's future. There is no element more critical to the strength of our health system than our health workforce. They are the absolute backbone. They ensure quality care, manage our data system, maintain our supply chains, and drive policy and innovation. Yet, for too long, we have outsourced key aspects of our health system than our health workforce. You know, we have, if you've looked at the last 20, 30 years of development in this continent, we have become experts in outsourcing these trainings to external organizations. We have allowed others to determine our education priorities, pulling our doctors and nurses into fragmented, donor-driven trainings, creating inefficiencies, and misaligning health priorities. So it is time to take ownership of our medical education, to develop a shared Pan-African curriculum that is grounded in our reality, focused on the diseases and health system challenges this continent faces, inquiry-based and competency-driven, fostering curiosity, critical thinking, and lifelong learning. Technology, we cannot avoid technology. That is the future. So technology-leveraged education, enabling AI, digital platforms, and simulation-based training to enhance their learning, and community-anchored, ensuring students are immersed in the health realities of the people they will serve. We cannot be training our doctors for export. It's fine if we train them and they end up leaving the continent. I think they still will serve extraordinary purpose. They will send remittance. They will get super specialized training and will continue to contribute, but we cannot train our doctors for export. We also have to build on research, discovery, and implementation science so that medical education is not just about learning existing knowledge, but about generating new knowledge to shape the future of healthcare. A strong medical education system is not just about training clinicians. It really must also be a catalyst for discovery. Research must not be seen as an afterthought, but as a fundamental pillar of medical training. We must advance research from bedside to bench to communities, bridging clinical care with scientific discovery, and ensuring that implementation science is at the heart of our medical education. Our research institutions and medical schools must be at the forefront of developing homegrown solutions for Africa's health challenges, whether it is maternal health, infectious diseases, or emerging threats like antimicrobial resistance. We must nurture a new generation of physician scientists and innovators who will push the boundaries of medicine, not just in laboratories, but also in hospitals, in communities, and health systems. And we absolutely, while I have all 137 of you in the room, we absolutely must bridge the gap. We need to align medical education with national health priorities. And what is happening in Rwanda that Professor Abeba gave a shout out to, a minister coming and opening the meeting, folks from the Ministry of Health integrally involved in the panels, and Minister Yvonne being here to close the meeting tells you what happens when Ministry of Health works hand in hand with medical institutions or training institutions. But for me, what I have observed is for too long, there has been a disconnect of our medical schools, research institutions, and ministries of health, resulting in a workforce that's, while clinically trained, is often unprepared to navigate the complexities of the health system. Right now, we see medical graduates being deployed as district hospital directors right upon graduation without the leadership, governance, and public health knowledge needed to run a facility effectively. So this has to change. We need to build stronger collaboration between academia, research, and policy to ensure that our graduates are systems ready on day one. Our training must include exposure to health policy, health financing, and systems management, so graduates understand the realities of running a healthcare facility, whether they work in public sector or graduate and go out and get employed as a physician or move on to set up their own private practice. Public health integration is another key, ensuring that doctors are not just treating diseases, but also focusing on preventing them through a well-designed health intervention. This continent cannot continue to focus on treating the sick. We have to integrate disease prevention and health promotion as part of our curriculum. So we do need a stronger synergy between medical schools, research institutions, and the Ministry of Health, so the education is informed by national priorities and graduates are ready to serve. A cohesive, well-integrated medical education system will ensure that the next generation of healthcare leaders is prepared to drive systemic change and not just deliver care. We also have to move beyond outdated models. We need to innovate at scale and for impact. And to achieve this transformation, we must move beyond what we've been doing, which is we all borrow models from other places. The reality is we do have a colonial model of medical education, and that's fine. It has served its purpose. If you also look at the Flexner model designed over a century ago, it has set very important standards, but also restricted scale and innovation. So we cannot be victims of the WHO statistics. You know, this country, Africa, has the greatest burden of disease. I mean, literally for the last 30 years, every health work conference I have attended to has one slide that shows how we have disproportionate disease, but very small number of healthcare providers. And we cannot radically change that if we continue to graduate 50 medical students a year. And we have incredible example from places like Ethiopia, my place of birth, where radical departure from the traditional method has scaled up medical education. Of course, you have to look at quality. It's not only about quantity. And the place that I call my place of nationality by choice, Rwanda, is now doing what we call 4x4, quadrupling the workforce in 4 years instead of doing 50 medical students a year and waiting for another 180 years to catch up. And we will never catch up because we graduate, they leave, we train more. It's sort of like this leaky bucket that you can never fill up. So the current model is very restrictive, and we need to think beyond that. We need to scale. We must rethink how we train healthcare workers at the speed and the scale this continent needs. This continent now is home for 1.5 billion people. So we just cannot continue the status quo. Beyond medical undergraduate education, the same needs to apply to expanding postgraduate education. For me, my personal experience has been an extremely powerful tool to retain your doctors in country. I haven't met that many physicians who will get up and leave their country to be a second-class citizen somewhere else in search of better pay. No. Oftentimes, they get up and leave because the conditions they work in does not allow them to practice and deliver the training they have received, and they can barely attain postgraduate and develop. So what we've done in Ethiopia over a decade was taken a university, a new, like a hospital that transformed to a medical school and launched very large numbers of residency training programs and subspecialty fellowship program. A residency program that I launched in partnership with the government of Ethiopia and my colleagues, which many of them are in this room, at St. Paul, in collaboration with the University of Michigan, was taking 7 residents per year for OBGYN. That program currently graduates 120 OBGYN residents every 4 years. That's scale. That's scale. And that did not require extraordinary investments. It required an extremely dedicated group of individuals who really wanted to make a difference. And with very little support, they were able to achieve that. So for me, as painful as it is to see foreign aid cut, one of the things that's going to bring is discipline. Because what we have seen is a lot of circus that takes our providers out. They cannot, our deans, our professors cannot practice in the way because every day they get summoned to do something on the side. And that's how they complement. So I hope out of this will emerge and governments will make the necessary commitments to allow universities and teaching institutions to work in the way they are intended to do, but also will bring discipline. That way we are not sort of dancing around doing all sorts of short-term trainings in resorts and hotels for 2 weeks and for a week and really undermine teaching institutions. The other thing I want to comment on is technology. I think we all have to embrace technology as a game changer. It gives us unprecedented opportunity to revolutionize medical education. Since the release of OpenAI in November 2023, ChatGPT and now Perplexity and DeepSeek, and they are coming Grok, they are coming at a pace that we cannot keep up with. I joke saying, literally, I'm giving like a hard time to my accountants, to my lawyers. It doesn't matter who I deal with. Overnight, you have the ability to become really knowledgeable on things. And for decades, we hear about how we don't have textbooks and we don't have resources. So if we make the necessary investments, AI-powered learning platforms can really personalize education, allowing our learners to learn on their own pace while receiving real-time feedback. Telemedicine and digital health platforms can be integrated into training. prepare our students for remote patient care and digital health management. And this is becoming a reality, not just in Africa. There is a lot of reverse learning that's taking place. I am a reproductive endocrinologist. I am an OBGYN, and I'm an abortion provider. Given the reversal of Roe v. Wade in the United States and the growing restriction and assault on women's bodily integrity and bodily rights, many states are now restricting reproductive health access. So we are now reverting to some of the methodologies that used to be very common and growing in poor countries, quote unquote, in third world countries who had to figure it out the hard way, right? How do you use self-care? How do you use digital health? How do you use telemedicine? These are tools we have to integrate into our patient care. And last but not least, the simulation-based learning. When I went to medical school, I never thought I would be in a crowd where I thought I was old. But literally, I look back, and that was almost 30 years ago. We practiced on human beings. It was the dictum was you see one, you do one, and you teach one. Right? I mean, imagine, you see one, you do one, and you teach one. That's how we are taught. And that is literally putting the people who've trusted us, to be used as a practice model. And that may have been necessary at times. I'm not passing judgment on how I got trained. But we now have a pathway to set up simulation, to ensure that learners are competent before they lay their hands on patients. So I think technology is going to allow us to do so much, but unless we embrace this innovation, we cannot scale, we cannot modernize medical education. So after your remarkable 2 days here together, I have a couple of calls to action leading hopefully for a change that we can all be a part of. We really cannot wait. Our newly elected president said, I will be misquoting you, but the time is now. You know what? Like, if not now, when? And if not us, who? Right? We are the right people. We are the people we've been waiting for. So my call to you is really to commit when you leave this room today, not just look at it as yet another meeting, another convening where we got together, but really take the commitment you made to create a Pan-African collaboration. Hopefully that someday will lead to a shared, at least minimum competency and a core curriculum that all African institutions can share. This doesn't mean that somebody in Cape Town cannot enhance, or a UGHE model will become a University of Rwanda model. But at the minimum, we can all bake in shared competencies and shared curriculum. We have to strengthen collaboration between medical schools, research institutions, and health ministries, ensuring alignment with national health priorities. We have to, we must, there is no way around it. We also have to embed implementation science and research into medical training so that our professionals are not just learning, but also generating new knowledge. We need to invest in postgraduate training and specialization, expanding residency programs, ensuring that specialists are being trained at scale and are being retained in the continent, not just trained and again leave. I will also say it is not as complex as we make it seem to be. It really, frankly, is not that hard, especially when we are so many jointly committing to achieving these objectives. And if we do this by leveraging technology, I really think we can achieve a lot. So the future of Africa Health is going to depend on this moment. We have a once-in-a-generation opportunity to reshape medical education. And by extension, frankly, the future of healthcare in Africa. The choice is ours. We can continue to be fragmented. We can continue to be using outdated system, or to really build a bold, integrated, future-ready medical education system that meets the needs of our people. So I really hope we'll seize this moment. In Rwanda, we are launching African Health Sciences University, AHSU, if you haven't heard about it. That is going to be linked to King Faisal Hospital It will be the future of the future medical school. It will be like nothing any of us have seen. It's also going to be a Pan-African institution, just like Africa Leadership University that houses students from all over, like UGHE, that students from the globe. We hope African Health Sciences University will be one that will open its door with Rwanda's open door policy for Africans without visa. We want the best in the continent to come here and not cross the Atlantic or drown in Lampedusa, being second-class citizens somewhere else. We do have an incredible opportunity to create the future together, and let us commit to work together across countries, across institutions, across borders, across disciplines to create a stronger, healthier, and more resilient Africa. Thank you very much.
Thank you very much, Professor Senayat. One of the tiny, tiny contributions to what you've called us to today is that from next academic year, the University of Rwanda School of Medicine and UGHE School of Medicine will teach the first 2 years together in unison. And that is just the beginning. Ladies and gentlemen, yesterday morning we had the privilege and the honor of having the Honorable Minister of Health open this conference. Today we have the distinct privilege and honor of having the Honorable Minister of State for Health closing our ceremony, closing our conference. I want to make just a few comments about the Honorable Minister, and you'll see why in a moment. The Honorable Minister of State for Health is a physician, a medical doctor, who holds a PhD in human genetics from the University of Liège in Belgium. But it may also surprise you to know that he holds a master's degree from the University of Global Health Equity. Ladies and gentlemen, somebody who has inspired many, many young people in health in this country for some time now. Please help me to welcome the Honorable Minister, Dr. Ivan Butera.
Good afternoon, everyone. Phil has mentioned some information, but he didn't disclose the other part. He also happens to be a Vice Chancellor of the University of Rwanda when I was in medical school back then. So he was my boss back then. And it's good to see some familiar faces in the room. I see Professor Patrick Kyamangwa, who was the Dean of the medical school when I was in medical school. So it's good to see you again. And the UGHE team, Joe, who I recall very well, gave us the second lecture after Paul Farmer had given us the first lecture, and that's about 10 years ago when we started the Masters of Global Health Delivery here. So it feels like family here, and colleagues, friends, Professor Senayat, and everyone in the room. So good afternoon, and I'd like to welcome you again to Rwanda, to Kigali. It's a pleasure being with you here today. I feel like a lot has been said. We have the most brilliant minds in medicine on the continent here in the room. So mine will just be some short, points that I think we can reflect on as we, leave this room, a consortium of this quality, of this number. We can agree on some of the things we can do together to advance medical education for health system strengthening on the continent. And I'll pick up on a point that Professor Senayat has talked about, which is linking health priorities with medical education. About now 2 years ago, 2.5 years ago, one evening we sat with my colleague, Minister Sabin, who was with you here yesterday, and we looked at the data of, number one, what are Rwandans suffering from in terms of health, Number two, what is killing them the most? So we looked at it and we found that the top 3 killers of Rwandans now, let's take a certain population and I'll talk about the subset. Let's remove the under 5 from now, and we take from 5 years of age going above. Number 1 is cancer. Number 2 is cardiovascular disease complications. Number 3 is metabolic disease complication, mostly kidney related. And guess what? None of these 3 things had a training program here in the country. So there was a huge disconnect in terms of burden of disease and medical education. But now that gap has been filled. And the last 3 years, we were able to launch 23 new fellowship programs here in the country that are hosted by the University of Rwanda, but through partnerships with many academic institutions, including some of which you have here. And this talks to the power of partnerships. The way we are doing our fellowship programs here in the country is that, let's say the University of Rwanda holds the program, but our fellows don't train at the University of Rwanda only. For most of the program, 50% is here, but the other 50 is done 2 ways. They go into high volume centers on the continent or elsewhere where they can do the practice. Also, they go to other countries where they will see at a system-wide level, how do you organize, because these are ultimately leaders of these programs. How do you work with finance? How do you work with research? How do you work with other departments? How do you work with the medical school, etc.? So that was one example of how to bridge health priorities with the medical education program that we have. So we launched a kidney transplant fellowship program here in the country. And that used to be the #1 reason for referrals abroad. It was also costing us a lot of money to send people abroad. But we've now completed, I think, about 44 kidney transplant procedures in the last 2 years or so. And they're all doing well, and the fellows are doing well. A cardiac surgery. In the same line, a cardiac surgery program is starting this year, but it's also building on what I was talking about, the power of partnership. And you know very well, the cardiothoracic surgeons in the room, when you're able to start a cardiothoracic surgery program, it's also a test of how mature your health system is. And thanks to partners and colleagues, the person who's launching this fellowship here in the country actually trained for his general surgery program at Jimma University in Ethiopia. He went on to do some training in Australia and Israel, but he's leading the program here locally, and it's going very well. Same for oncology that we launched last year. So linking the priorities of the country to the medical education is something extremely important. And I think as a continent, if we are able to readjust our plans going forward, it's going to take us very far. But here also, I said I will talk about live cases. There are some of the things I think, be it councils or regulatory bodies, we can adjust going forward. And I'll give you a practical example. When we're about to launch a kidney transplant program here, some of the institutions we're working with had reservations. You cannot start a program if you don't have a local champion. If you don't have a kidney transplant surgeon, you're not starting your kidney transplant fellowship. But that defeats the purpose. In the first place, I don't have a kidney transplant program because I don't have kidney transplant surgeons. So we have to be humble enough to say, okay, can we get help from the beginning with a clear plan of transition as we go forward? But these are rules that are written, in the curriculum somewhere or in the rules of the regulator somewhere. Having the flexibility of, going around things when it makes sense will help us move fast and forward and efficiently with logic. So that case that I'm talking about, it took us about maybe 3 months. I don't know if Menelas is in the room, he remembers, to convince that we can start a kidney transplant program with a visiting faculty that can come, every month for 1 week. And this had been done in other countries, but now the program is running very smoothly. But these small moments, if you don't push enough, might make you take a pause and say, okay, maybe I'm not yet ready. I'll wait for a kidney transplant surgeon to train somewhere in another country, then to come back home. But with that, you're losing a lot of time and money. So I think as we are colleagues here with different bodies, the medical school, the regulators, the councils, to try and find synergies of answering an issue that the population demands, because at the end of the day, we are accountable to the community. What they want is to get the services, and we have the responsibility to give back that service. And another area is, we've had a decline in maternal mortality of 3/4, neonatal mortality, same 3/4 in the last 20 years or so, but we've been stagnating in the last 10 years. And this is where we looked at the data and we're like, okay, what are we failing to do? And I'll pick two things. For neonatal mortality, the kids we are losing are prematurity, low birth weight, very low birth weight, and extremely low birth weight. And two, cardiac malformations or other congenital malformations. But we didn't have a neonatology program until 2 years ago. We didn't have a pediatric cardiac surgery program until this year that we're about to start. But there are other things that go on with that, biomedical technicians, midwives, nurses, specialized nurses that work within specialized units. So really adjusting our priorities to what we can deliver, I think, is extremely important. The third point that was extensively discussed in this meeting that I want to touch upon is the research part. I think we do quite very well in doing epidemiological research on the continent. I think we can do way better in doing translational research on the continent. I'll pick two examples that we saw when I was still in clinic. You saw very atypical presentation of breast cancer patients, very young, aggressive, 23-year-old lady, triple negative breast cancer, because that's what you test for. You don't have any other markers. And they are not responding to treatment. But we just stop it. We just stop there. I'm seeing young ladies with triple negative breast cancers. They're very young, they're aggressive. If you take gastric with no, known risk factors, very young as well. But there's something we are not unlocking. I think, and this is where I think physicians can take the lead of training physician scientists, of really understanding what are we having, what are the issues that we have, either inherently or environmental related, so that we can go to the next phase and actually design maybe molecules that will work better for us on the continent, so that we don't just diagnose and prescribe the wrong treatments, but tailor the treatment. So precision medicine can really come from physicians, and I think we can still work with people in pharma, but I think the medical education needs to come up with this. Now, one other layer to add upon it is technology. Paulin just left, but I know we discussed this a lot. He's very passionate about technology, how we bridge AI to health education, be it in health education, but also in drug discovery. And this can only be coordinated, I truly believe, by people who understand the needs of the people which are physicians. So I just wanted to leave you with these few reflection points of how we can improve our health systems through the window of medical education. And I would like to really thank you, all of you, the organizers. You've done an incredible job gathering 139 medical schools. The consortium of that quality is unprecedented. We hope that the commitments that were made here will turn into action. The vision that we have will turn into impact, and we want to assure you that Rwanda will always be with you in any innovation, anywhere you are, any idea, any partnership, to make sure that we drive the development of our continent, particularly today talking about medical education. I'd like to thank everyone that has come from far. We hope that you will regularly come to the country, all our partners, our friends, our colleagues. Thank you very much for all that you have done. The students in the room, residents, fellows, I think this is a turning point into medical education. Being in the room where these points are discussed over the last 2 days will give you kind of like a roadmap of what you can do when you go back, the connections you have forged between your colleagues, because in the next few months or years, you'll be in the decision-making chairs, and you'll have the role to advance healthcare of the continent and the globe to a certain extent, because you'll be 1/4 of the globe in a few years to another level. So it's a heavy responsibility, but you also have all the tools within you. So I'd like to thank you all. And with that, I'd like to officially close the MedEd 2025 and hope to see you again very, very soon. Thank you very much.
Thank you, everyone. Just a small announcement. All the students, please meet in AD 12. And for all those that are breaking their fast, you will have your meal at the Radisson. Thank you, everyone. It was amazing being your host.